Hi guys, this is Gigi. How's everybody doing? I know I promised I would do another video much sooner, but I've been very busy. But finally, I'm here making what I've promised I would do. So I hope everybody's doing well. I'm doing great. Everything's wonderful. Last time we spoke, or last time I made a video, I was 3 months into being in the position as an acute care nurse practitioner role. It's been 3 more months fast forward now. So far I've been in this position for 7 months. I passed probation. Everything is well. Work is very stressful. I'm never going to stop saying it because it takes a special type of person to be an acute care nurse practitioner because the stress level is always there. Again, this is why we're in ICU or patient are very extremely unstable the majority of the time. This is why they're in ICU. So you have to love what you do in order for you to do it. So that being said, if you are emotionally you have to be prepared to be in this position. I'm just being honest. So it takes a toll on you, so you do need to take time off from time to time. You go to work, you do your couple of shifts. Like right now my schedule is a 3-4. One week I work 3 days, the next I work 4. So you need to take time off and relax yourself and go out with friends or loved ones or whatever you do to help you relax. Yoga, you have to do something. All right, we're gonna put that in the back now. Today I told you I was gonna talk about the book that I use, like my ICU Bible. Because I'm in CV, I'm strictly cardiac, I use this book. It's called Manual of Perioperative Care in Adult Cardiac Surgery. It's by Robert M. Bouchard. Okay, disclaimer, any books I'm going to talk about, I have no affiliation whatsoever with the publishers or the owners of the books. I just use the books. They're very helpful to me, so I thought I would share them, but I don't have any kind of monetary gain from talking about those books. So if you're going to be strictly in CV and do a lot of cardiac care, cardiac ICU, this is the book for you. I've read a couple of chapters. I'm not done reading the whole book. It's a lot, as you can see in the small prints, but it's very awesome information. So I'm going to hold it still if you guys want to write it down. This is the book if you're going to be strictly doing cardiac, like cabbages, LVADs, ECMO patient, impellers, those kind of patients. This is the book for you. Now, if you are in a general ICU, like let's say a general critical care that's not strictly cardiac, you can use, let me see, it's not upside down, the ICU book. I don't have the ICU book. I think I have an older version when I was at the bedside as an ICU nurse, but this book is also very helpful. It's called the ICU book, and it's by Paul L. Marino. Again, no affiliation with the owner or the publishers of those books, but they're very good books. So if you're strictly in a general ICU, this is going to be the book for you. Okay, now a couple of questions people have asked me. One of my subscribers asked me, how's nursing school comparing to NP school? Nursing school, you're learning the basics, as I responded earlier. You're learning the basics, so you don't know anything about it yet. When you're in NP school, you kind of have the basic knowledge and you're just kind of building on what you know. It's a different kind of hard. Nursing school is hard because you don't know it. NP school is harder in a way, not harder, but hard as well, because now you're not thinking as a bedside nurse anymore. You have to get into the mind frame of thinking like a provider. So now what I've done a lot, if I can't remember, okay, what do I do in this situation as an NP? What kind of orders I used to have when I was at the bedside? What did I usually give to that patient? What was ordered for me by the providers when I was at the bedside? So that kind of helped me. Again, always ask. It's always okay. I teach ACLS also. I always say it in my classes. It's always okay to not know, but it's never okay to not know and do anyway. You're going to kill somebody. You have to be careful with that. It's okay if you don't know. You can ask multiple questions, but you cannot not know it and then, oh, I'm still going to order this medication. I'm not sure what kind of side effect my patient's going to have, but I think this is a good medication for this patient. You can't practice like that. You have to know side effects and different stuff like that. So yes, nursing school and NP school, they both challenging, but in their own level. In NP school, you do a lot of writing papers and research papers, a lot of group presentations, group projects, or whatnot. Okay, this is that. My other question was, where did I go to school? I live in South Florida, so I went to Berry University. There's only 2 schools down where I live that had the acute care program. Only University of Miami, or Berry University. Berry University is a longer program. has a longer program, but also has a shorter track. I think it's like a year or a year and a half, I want to say. My program was like 30 something months, like 37 months or whatnot. So I have a son, I have responsibility. I had to work the whole time I was in school, so I could not just strictly go to school. I still work full-time as a registered nurse at the bedside in ICU, and I also run a side company teaching ACLS, BLS, and PALS on a regular basis the whole time I was in school. So the 1 day a week class was what was suitable for my lifestyle. So if you have no children, or if you have kids, you have the help for you to go fully full-time. If you're in South Florida, maybe UM is better for you for fast track. But if you have other responsibilities and you have to work, maybe Berry University or the longer track for UM. Again, I have no affiliation with the schools either as well. So now, today, what I wanted to talk to you guys about is going to be how to present a patient en route. Where I work right now, every morning we have to give report to the CT surgeons, the residents, the fellows, especially on Thursday mornings, because we have grand rounds, everybody's there. So you have to present your patient. So you kind of have to know your patient. I'm gonna go into order the way I present my patients. Again, this is not written in stone. This is what I do, and I'm sure, please comment below if there's a better way for me to do it. We always open to learning and, learning more and getting more knowledge. Okay, I'll start. On this video, I'm just going to present the whole case from history all the way down to lines or whatnot. And then in another video I'll go into details what to look for by each system. Okay, here we go. Good morning, and whatever. This is a 74-year-old African-American female who presented with respiratory distress secondary to COPD exacerbation. Subsequently, patient respiratory arrested and was intubated. And during intubation, patient vomited. Okay, today is vent day number 2. Past medical history, diabetes, hypertension, and COPD. Okay. Neurosystem. Currently, the patient is sedated on propofol at 5 mics and fentanyl at 75 mics. On sedation vacation, the patient is able to follow commands and move all extremities. Okay, you go into pulmonary. Patient is ventilated on an assist control mode, rate of 14, tidal volume 475, PEEP 5 and 100%. And this is ventilator day number 2. Patient has minimal secretion. Chest x-ray is improving. Patient is on nebulizer treatment. Okay. There would be a time you talk about your pressure support trial or your CPAP trial. But again, in the next video, I'll explain all that. Cardiac wise, patient is sinus rhythm. Heart rate runs 75 to 85. MAPS in the 70s and 80s. Patient is not on any pressors. Last echocardiogram was done on date. The EF is 45 to 50%. The right ventricle function and the left ventricle function, you should note that, is it enlarged or what's going on. Cardiac as well. The patient's CVP runs between 10 and 14. Okay, that kind of gives us a fluid status for this patient. GIGU. Patient's got a Dobhoff, which is post-pyloric, and is receiving Glucerna. Patient was a diabetic. Glucerna at 35 mLs per hour, which is goal. Okay, and patient is tolerating the feeding well. GU. Patient's got a Foley, clear yellow urine. Patient voice with the Foley about 80 to 100 cc's per hour. Eyes and nose, patient is negative 500 today over 24 hours. ID. Patient was pen cultures upon arrival. Right? So far, cultures negative and pending. Patient was started on vancomycin secondary to aspiration wrist. When the patient got intubated, the patient vomited and the x-ray wasn't so good looking initially. So you have to say the patient, what antibiotic the patient is on. Lines. Patients got a right arterial A line that was inserted on admission, which is 2 days ago. Patients got a right IJ triple lumen that was also inserted. Today's day 2. Okay. And also you want to go into the medication. What medication is the patient on right now? Whatever medication the patient was on before, you have to review those med. Are the patient still on those med on what can be resumed or whatnot? Labs. You go into all your labs. You go into your CBCs. You're not just going to read the numbers because everybody can read numbers. You want to make sure you look at trends. How's the hemoglobin? If it was 7.5, let's say 8.2 today, and yesterday was 8.4. That's not a big jump. Okay, patient has no sign of bleeding. If your hemoglobin was 10 yesterday, today is 8.2. That's like a 2-gram drop. So you want to know what's going on with the trend. Is the patient's bleeding? Any signs of bleeding? Now the patient was negative 500. Now is the patient hemoconcentrated? You need to look at all those things. People don't want to just hear the numbers. They want to know what you're doing with the numbers. Okay, so that's your CBC. Your Chem 7, we usually do a CMP, complete metabolic panel, because it gives you the liver function as well. So with your Chem 7, you want to know, okay, your electrolytes, but we don't care if it's your potassium is normal. We want to know, okay, what's the abnormal? If your potassium was 3.2, did you replace potassium? If your potassium was 6.5, did you do something about it? Did you give some D50 and insulin and K-Excellent or calcium gluc with NEB treatment or whatnot? What did you do and what's the repeated value? Your liver enzyme you want to know as well, because you want to know what's the patient on Crestor or other stuff that you can get rid of. Is the liver enzymes going up or down? This is how I present my patients in the morning and the grand rounds that we do. Again, this is just a guide. This is not like how it should be done for everybody. If you have a better way, I'm always up to learning. Please share with me how you do it. If there's other acute care NPs out there that who do something differently, please let me know. Again, I will be doing another video to explain to you guys all the numbers, what do they mean, and how do we go into details. I just wanted to present how you do a general presentation. Key stuff you have to just remember there. You have to present the patient, like the current history. What did the patient come in with? Past medical history, okay? Neurostatus is important, especially if the patient is sedated. You want to know what's going on. Cardiac wise, you go to pulmonary, GIGU, IDs, meds, and then lines. And then the last one will be the plan of care for the day. What is the plan for this patient for today? Are we going to try to extubate the patient? Does the patient still need all the lines because we have to worry about line sepsis? Are we trying a ventilator trial today? Those different type of things. All right, guys, this is it for today. I will come a little sooner than 3 months, I promise. So if you have any questions, please post them. Let me know what you want to hear. And then this is a journey that I'm trying to do with everybody who's into the same track or who's thinking about going to NP school. It's nothing personal. I don't get anything from doing those things, but I just love, everybody who knows me knows I love to share knowledge. If I know something, I share with everybody. This is how we make this world a better place. You have to share what you know with other people. If you can improve what somebody else does, this is good. This is good stuff. So anyway, again, just to recap, if you're in a general ICU, that's probably the book you should be using. And then if you are in strictly cardiac, this is your Bible for the cardiac ICU. Again, that was Gigi. You can follow me on Instagram at GGMC2011. Also on Twitter at GGMC2011. My website is also www.gm-gmmedicalconsultants.com. That's www.gm-medicalconsultants.com. Again, I'm always open for positive or negative. Like I said the last time, this is how I improve. If I don't know I'm doing something wrong, I can improve. But if I know, you put negative. If you don't like, I don't care, give me a thumbs down. And then but put a reason why you give me your thumb down, so I know exactly how to improve next time. Again, this is Gigi. Have a good night. Bye.